everyone. My name is Chinenye Odo. I am a second year resident of internal medicine at the University of Pittsburgh. Today, I have the pleasure of interviewing one of the gurus, experts in community based participatory research, Dr. Ravenell. He's associate professor at the NYU Grossman School of Medicine. It's a pleasure to have you here.
Thank you so very much. It's a pleasure to be here. One quick update, I was actually just promoted to professor.
Oh
So,
my God. Well,
yes.
congratulations.
Thank you very much.
Well, today I have the pleasure of talking about one of the key trials today at ACC, and that's the Community to Clinic Linkage Program to improve hypertension control at the Barbershop. I will tell you, I've been a big fan of your work. I've followed the Barbershop initiative for a while. I will ask a question that came to my mind the very first time I picked up the paper, and that is, what is your inspiration behind this project? What is the story behind that?
Well, terrific question. So I want to admit here that I did not come up with the barbershop idea. The barbershop idea actually goes all the way back to the 1960s when the American Medical Association demedicalized measuring blood pressure as a way to try to curtail the epidemic of hypertension in Black communities. And so many Black communities led by Black nurses and Black cardiologists, including Dr. Keith Ferdinand, who was on the panel today, the late Dr. Eli Saunders, and many others actually started to engage community-based organizations such as churches, such as schools, such as barbershops, to go and measure blood pressure of members of their community so that they could be aware and go and get their blood pressure treated. And so one of the organizations that they focused on was barbershops. And so when I learned about this, it was from the late Dr. Ron Victor, who was my mentor. And he actually had the idea of actually studying this very rigorously to see if doing work in this trusted setting could help to identify young Black men at risk for real cardiovascular adverse outcomes, to see if this very special place could be helpful. So
that is
yes.
Truly inspirational right there. Okay. And just keying in on the trial, what would you say was like the biggest challenges that you experienced? Because we're talking going into the community rather than bringing them to the clinic.
Yes. So this was such an exciting trial because we were able to engage with over 60 community partners in Staten Island, New York. Staten Island is a very interesting place, but it's an important place because 90% of the Black residents in Staten Island live on what's called the North Shore. It's also where we see the highest prevalence of hypertension in Staten Island. And so we were able to work with this incredible community, engage with 22 barbershops, and I think one of the most rewarding parts about this study is that community health workers did all of the research as well as all of the interventions as well.
Amazing.
So this was a community health worker organization called Community Health Action of Staten Island, and they have been doing work in Staten Island for the last 30 years. So when we were connected to them, seeing all the great work they did, this focus on hypertension was a natural extension of what they were already doing, and they already knew so many of the community members, and so they really did, so much of the work. And I think the trust that those community health workers built over those decades being in Staten Island are really what were responsible for the 90 and 95% retention rates that we saw at 12 and 18 months.
That is so awesome. So trust is key is what I'm hearing.
Trust is key.
Okay.
Absolutely.
And what advice, is probably be my last question before we pivot. What advice would you have for future researchers who are interested in community-based participatory research, who might be wanting to model what you had with the community extension workers?
The best advice I have is to be patient, number one, and number two, there are no shortcuts.
Okay.
Anything that you invest in those relationships with community leaders and with key opinion leaders is going to be important for the success of whatever you're trying to achieve.
Amazing. Okay. All right. So we're going to, in 1 minute, just give a summary of the key trial design methods and findings.
So the Community to Clinic Linkage Implementation Study, or CLIP, for short, was a study looking at two implementation strategies for a community health worker based program to screen for hypertension and screen for social needs in 22 barbershops in Staten Island, New York City. And so the study ran for 18 months, and we recruited 430 men from those 22 barbershops. And over the primary outcome was actually change in systolic blood pressure from 0 to 12 months. When we looked at the two implementation strategies, one that was what we call a facilitated strategy, the other one was what we call a self-directed strategy. The facilitated strategy featured a barbershop facilitator whose job it was to help address any barriers to implementing this CLIP program. So when we looked at the two strategies, we saw that there was very little difference in the amount of change in systolic blood pressure. Both strategies basically kept the systolic blood pressure relatively level. We didn't see the decrease that we wanted, but we were actually even happy to see a sort of a leveling of the systolic blood pressure. So what this study tells us is that community health workers can actually implement these programs, and we did see that very few of the men progress to stage 2 hypertension. So it really is a viable approach to addressing hypertension disparities among Black men.
Amazing. Well, you heard it here, guys. And more information on this would be both on ACC and on Fit So to Go. Thank you.